Hey, this clinically relevant is going to be a little bit different because it's about me and my experiences. So I titled it "When a Toothache is Not Your Teeth," right? So give you the thing. I woke up one morning, December 3rd, here recently, and I had never ever had these symptoms before, but I've seen these symptoms in the clinic 100 times. I essentially woke up with aching, like a deep aching in my teeth, both sides, but really more on my right, like I was clenching all night long. As the day went on, the morning went on, it started coming up into my maxillary region, almost like a sinus thing, and then it started to go up into more my ophthalmic division, not so much temporal, but just more in the frontal areas. Um, and what's cool about it, interestingly enough, was that I didn't have a mechanism injury. I've never been a clencher before. I'd never been a grinder. I didn't have any recent dental work. I wasn't sick. Didn't have any nasal drainage. Nothing along those lines, right? It was almost in a migraine distribution, ophthalmic, but I don't have migraines. Certainly didn't have any neck pain, and I didn't take any medications. Of course, I did something better than taking medication. So, a couple of questions when we think about a dysfunction like this is what is the source of pain? So, obviously, in this particular picture, it really came along the lines of the maxillary distribution and sort of crept up into more of the ophthalmic division of the trigeminal nerve. And why would that be? Well, it was some form of neurogenic inflammation, right? You can't have pain unless a nerve is irritated, and most nerves that get irritated have some form of inflammation, right? So, what are we going to do with something like that? Well, like I said, I didn't take any medication or anti-inflammatories because I already have the best anti-inflammatory known to man, and that's dry needling. So, essentially, I took half-inch needles and I just set them in these different locations, right? So, here's a good picture of that. Now, you're going to say to me, the students are going to say, the IDN clinicians are going to say, hey, you're way too high on the supraorbital, and you're right, but you try to stick needles in your face in a mirror, right? But I stuck them into this distribution into supraorbital, procerus, infraorbital, which is basically covering maxillary, and I put one more towards the mental. As I said, these are basic half-inch needles, right? I'm not sticking them in. I'm not needling, doing twitching or deep needling. It's only really cutaneous types of needling in these different distributions. I left them in there for about 30 minutes. I just went on with my day and, did some work and whatever else. But what was interesting is really reproduce the very familiar symptoms, which is what we want, right? So very much really a deep, dull aching that actually lasted that whole day and into the evening before I went to bed. Now, next day, December 4th, I woke up, all the symptoms were resolved. Never had them again. It's around December 19th right now. So when we look at the next question on this is there any research to support this hypothesis, right? Well, we did a study. Dave was one of them from another IDN instructor. And we knew that when people had cervicogenic headaches, we hypothesized that if we just needled superficially into the trigeminal distribution, that we'd affect their cervical complaints through the trigeminal cervical complex. And lo and behold, just by doing superficial needling in these particular areas, very similar to what I did, and we added a little auriculotemporal, but just the superficial needling here changed cervical range of motion, pressure pain thresholds, and certainly the cervicogenic headaches, right? And again, it was very simple type of targeted specific cutaneous needling, right? Now, when we look at the relevance of this is when we get a nerve that has inflammation, neurogenic inflammation, if you do the appropriate needling to it, in particular to the neural afferents, because obviously you need needling that affects the neural afferents, but also you create non-neural components like mast cells and different things that create different types of transmitters and signaling molecules, you actually get a really strong anti-inflammatory effect. And I think that's exactly what happened in this particular situation. I targeted the infraorbital and supraorbital. Now, granted, it's not the maxillary nerve, the deep nerve, but because a nerve has a flow, it has an antrodromic and orthodromic flow. If you have inflammation in one part of a nerve, you have inflammation in the entire nerve. So we targeted areas that we could get to, the windows, as we call homeostatic points, targeted those windows and had a kind of almost a retrograde effect on affecting the anti-inflammatory effects and reducing the neurogenic inflammation. And amazingly, it cleared. So if you want to know more about how we do very specific neurologic dry needling, this is our link tree here, or visit our website at Integrative Dry Needling. Hope you liked it. Thanks.